Hi, my name is Dr. David Rubin. I'm from the University of Chicago. Welcome to this special program. On behalf of CME Outfitters, it's my pleasure to invite you and to welcome you to the program that we've put together for patients called Who's in Charge, You or Your Crohn's Disease? I'm really looking forward to a conversation with my very good friend, Dr. Bruce Sands from Mount Sinai Hospital in New York City. Dr. Sands and I will be discussing management of Crohn's disease and, very importantly, an update on new guidelines that have been published related to the management of Crohn's disease. We both feel that it's very important for patients to understand these guidelines and certainly to understand the advances that have occurred in managing Crohn's disease so that you can take charge of your Crohn's disease, or if you're a loved one who has a family member with Crohn's disease or someone that you care about, you'll understand how to support them. And we hope that you'll find enough information during this program to have an informed conversation with your healthcare team and the people who are managing your Crohn's disease when we're finished. I want to again say that I'm Dr. David Rubin. I'm very pleased to be doing this program with Dr. Sands. We wanted to start actually with a little history of Crohn's disease and a bit of ulcerative colitis. I'm actually the Joseph B. Kersner Professor of Medicine at the University of Chicago. The name of my professorship is named after Joseph Kersner, who worked at the University of Chicago his entire career focusing on inflammatory bowel disease and lived to be 102 years old. Dr. Kersner saw patients until he was 95 and came to the hospital every day until well after he was 100 years old. So it's really my honor to have his name as part of my professorship. But Dr. Sands has an even more distinguished title. He's the Dr. Burrell B. Crohn Professor of Medicine in the Dr. Henry Janowitz Division of Gastroenterology at the Mount Sinai School of Medicine. And I thought Dr. Sands could tell us a little bit about Burrell Crohn and about your professorship.
Right. Burrell Crohn was a legend, certainly at Mount Sinai, but in the world of gastroenterology, who described with his co-authors Ginsberg and Oppenheimer the first case series of what we now call Crohn's disease, but they didn't call it that. They called it regional ileitis. Truthfully, there were a few other groups across Europe that may have described what we now call Crohn's disease before that, but the recognition came to this group. And he also was long-lived. He lived late into his 90s.
Yeah, so I think the doctors who study inflammatory bowel disease live a long life, and hopefully that'll
David.
be us too. So in this picture here, this is Burrell Crohn, right?
Yes.
And is he flanked? This is Leon Ginsberg, I believe, or is that Oppenheimer?
I'm embarrassed to say that I can never tell them apart, but Janowitz, who our division is named after, is right there.
Yeah, so this is a very famous picture of one of the first grants that was given for research related to IBD, I believe. So we're really happy to have you with us tonight, Bruce, and obviously you carry on a wonderful legacy at Mount Sinai. We're going to talk about the new guidelines in Crohn's disease and try to help patients and their family members understand what we know about Crohn's disease and some of the significant advances that have occurred. And we're very pleased to share with the audience and to make sure people know that we've made some great progress. We always remember, though, that there's more to do. Ultimately, of course, we want to understand the cause and cure these conditions. In the meantime, however, we want to emphasize that there have been some tremendous advances in medical therapy and, very importantly, understanding how to control the disease and provide high quality of life. Let's review briefly, though, what Crohn's disease is. Crohn's disease is a condition that is characterized by chronic inflammation of the intestinal tract. By chronic, we mean that it lasts a long time and in most cases diagnosed at a younger age and then may last a lifetime. There are some people who are not diagnosed with Crohn's disease until they're a little bit older. Technically, Crohn's disease can involve any part of the GI tract, but most commonly we find it at the end of the small intestine in the area called the ileum, where it connects to the large intestine. The cause remains unknown. There are lots of different theories about this, but in general we describe it as an overactive immune response. Remember that the immune system of your intestine exists to help you distinguish from things that might harm you from those that you need for nutrition and health. And what we've come to appreciate is that in Crohn's disease, the immune system of the intestine is overactive or continuously stimulated, or both. And that's what leads to progression of the disease and causes symptoms and may result in some complications. We characterize Crohn's disease as either relapsing and remitting, meaning that sometimes it's very active and sometimes it shuts off and it's quiet. And in some cases, we've come to realize that the Crohn's disease inflammation may progress, causing a complication over time, like a bowel obstruction or penetration to other organs within the body. There have been some new treatments developed, and we'll be talking about those tonight. Now, one of the features of Crohn's disease is the inflammation causes thickening of the bowel. In this particular slide, you can see on the left side a normal segment of small intestine, and on the right side what it looks like when it's inflamed with Crohn's disease. This is distinct from what we see in ulcerative colitis, which tends to be more superficial inflammation. In Crohn's disease, it can involve the entire thickness of the intestine and then involve other organs or cause an obstruction of the intestine, which is an important feature of Crohn's disease. About 15 to 20% of people with Crohn's disease have a feature of their disease called perianal Crohn's disease. This is focused on the very bottom of the large intestine, an area called the anus, which is below the rectum. And in this situation, patients develop inflammation that may bore through the wall of the anal canal or the very bottom of the rectum and cause a track or a connection from the inside of the bowel to the tissue around it and ultimately to the skin. Those abnormal tracks or connections are called fistulas. And in the cartoons, you see the difference between a simple fistula, where there's a single track here that would be draining from the outside of from the inside to the outside of the body. And closer to Dr. Sands, you can see what we would call complex fistulas, where there's more than one, or they make turns within the tissue around it. As you might imagine, perianal Crohn's disease can be very uncomfortable, can have a poor quality of life associated with it, and in our management strategies, we focus on patients who have these conditions and treat them very aggressively to make sure we try to control the inflammation. This is also a condition of Crohn's disease that sometimes needs help from our colorectal surgery colleagues, either to clean up the draining areas or to help us heal those areas. And Dr. Sands will talk about some of the treatments we use for this in the future part of this presentation. Now, what we're going to be talking about and what stimulated us to do this presentation today is that in the last year, there was a new guideline for the management of Crohn's disease that Dr. Sands was one of the important authors on for the American College of Gastroenterology. And then there was also a new guideline related to ulcerative colitis, also for the American College of Gastroenterology. Our other society, the American Gastroenterological Association, also came up with some new guidelines and care pathways. So there have been so many advances in our field that we felt it was really important not just to educate our colleagues on these diseases, but also to teach patients and their family about some of these advances. So what are clinical practice guidelines? Well, guidelines are designed by experts in the field to summarize the available best evidence and opinions about managing a condition. And in this case, we're talking about Crohn's disease. The recommendations are meant to reflect the best available evidence, that means scientific studies that show specific outcomes, and to provide clinicians with recommendations and suggestions about how to best manage. They're not always set in stone, and they're meant to guide us. They don't necessarily mean that it's the right treatment for everybody, but they're very important. So guidelines, when they come out, often try to move the field forward, to acknowledge advances we've made, to identify areas where there's still some controversy or things we don't know, and to help us move along and take better care of our patients. When we look at guidelines, they're based on different levels of scientific evidence, and we have a grading scale for how strong the evidence is. They start with things that are just based on good practice or the opinions of experts without necessarily the strongest level of evidence. There's some value in that. Certainly master clinicians and people who take care of lots of patients have some ideas about what might be good. But beyond that, we look to more scientific evidence. This may start with reports of cases of situations with specific outcomes, and then stronger levels of evidence evidence include what we call randomized clinical trials, where patients are randomized to one treatment strategy or another, and we look at specific outcomes in terms of how they do. And ultimately, the strongest level of evidence is when we have multiple randomized trials, all with similar findings that we can combine into knowing that what is seen and what has been done is likely the best approach. So guidelines combine all these different levels of evidence to come up with strengths of different types of recommendations for practitioners. What we're trying to do here now is to summarize them for our patients. Now, what we've learned through a Twitter poll and, of course, through talking to our own patients in practice is that very often patients don't know that there are guidelines, or certainly don't know that there have been new guidelines published. So that's partly why we developed this program tonight. And we've actually interviewed some real patients and asked them to comment on whether or not they knew there were guidelines. So let's listen to what a couple patients had to say.
Of IBD patients are very confused, and there's a lot of misinformation on the internet.
I don't think that patients are aware of clinical guidelines very much at all.
So you can see from these patient examples that many patients are not aware of what the guidelines are. Now, we also recognize that there are limits to these guidelines. You might think or hope that all of the people who take care of patients are aware of the latest guidelines, but that's not always the case. So we have other efforts that we make, including some of our national meetings and in other methods to try and make sure our colleagues are up to date on some of these guidelines. They also have a tendency to become out of date quickly. It takes a long time to get a guideline through all the different review panels and appropriate publication channels, and then there's new evidence. So as soon as a new guideline comes out, it may already have some pieces of it that need to be updated. It's a little bit like throwing a pass downfield and expecting the wide receiver to be where you need it when the ball comes down. So we try to think ahead so that we can move the field forward and it's not going to be out of date as soon as it's published. The other challenge to guidelines, and I want to emphasize this, is that it doesn't always apply to everybody. So we recognize that Crohn's disease and ulcerative colitis can be very heterogeneous. There are lots of different types of diseases within these diseases that we call Crohn's and colitis, and therefore individual patients may need something that's a little different than what the guidelines suggest. And lastly, despite our efforts, the people who pay for some of our expensive therapies may not always agree or even be aware of some of our newer guidelines and the levels of evidence, maybe because the therapy is so expensive or maybe because they just don't make that a priority for them. So there are lots of limitations for us to realize and think about with the guidelines. So Dr. Sands, if you could spend a moment now and take us through some of the thoughts about these guidelines, tell us a little bit about the ACG guidelines that you were part of and how we should be thinking about this.
Right. As you said, the creation of guidelines is a very rigorous process. It takes a lot of thought, a lot of effort, a lot of delving into the literature and sifting through the evidence. So it begins with a committee of people who are assigned to do this. They look at all this evidence and they grade it and then come out with statements of what should be more or less a standard of care. So this was done it took more than a year actually to create the ACG guidelines, the American College of Gastroenterology guidelines for Crohn's disease. And you were spearheading the ulcerative colitis guidelines at the same time, which we're not talking about here. The AGA has also updated their guidelines. They had a more focused guideline related to the use of thiopurines, methotrexate, and anti-TNF biologic drugs in the treatment of Crohn's disease.
So why have two different sets of guidelines? Wouldn't they all be the same if we're using the same evidence?
Well, mostly they do overlap, but some of the approaches can vary depending on how the experts may think of it. And as you also pointed out before, some of this, because we don't have evidence for everything in the literature, some of it has to be content provided by expert opinion, and that's where they can differ.
So what's new in the guidelines that came out last year? Tell us some of the things that our patients should know about or that we should be looking forward to.
Yeah, well, historically, we have tended to treat patients in what was called a step-up approach. We would start with a base of treatment, which was perceived to be maybe a very safe, but maybe not the most effective treatment. And then if the patient didn't respond, we would ratchet it up to the next level of treatment, sort of this pyramid approach. We have recognized over time that that is probably not the most effective way of treating patients with Crohn's disease, because while we're trying to get it right through trial and error, often the disease is progressing. So there's an urgency to treating the disease very effectively. And therefore, we want to take into account the patient's prognosis. We want to try to predict what the course of the disease will be like so that we match the treatment to the appropriate level of prognosis for a given patient. So we're thinking more along the lines of how do we tailor the treatment for the patient. And that's where the second new principle comes in, which is this treat to target approach. To treat to target, and I'll explain this a little bit more in a moment, is really to keep in mind that we're trying to achieve a number of important goals in treating Crohn's disease, and we don't want to lose sight of those goals, and we want to make sure that both the patient and the physician know what the appropriate goals are and to try to hit those goals. We'll talk about that more in a moment. Also, the guidelines had to incorporate newer treatments beyond the traditional conventional therapies, which included steroids and immune modulating medications like azathioprine or mercaptopurine, and these certainly include the anti-tumor necrosis factor antibodies, which were the first biologics we had, and we've been using them for more than 20 years. But in the last 5 or 6 years, we've had the addition of vedolizumab and ustekinumab, so those had to be incorporated. And then finally, yet another means of tailoring the treatment to an individual, which is the approach of therapeutic drug monitoring. So we can, in some cases, measure the levels of drugs and adjust the dose of the drug to make it appropriate for the individual to achieve the best responses.
So you mentioned this treat to target. Can you just explain a little bit more? Because I think that's one of the most significant advances to thinking about how to move people through different treatments when they're being managed with Crohn's disease.
Yes, I mean, you could think of the treat to target approach as a cyclical kind of repetitive process. It isn't just something that you do once. It's something that you have to keep in mind continuously as you go through treatment. And basically, we have defined in Crohn's disease what appropriate targets are. We'll talk about those in a moment. We'll begin a treatment, but we don't want to just assume that the treatment is going to work. We want to assess whether the target has been achieved. And if it hasn't been within a certain period of time, then we want to adjust treatment appropriately and then reassess the target to see if we hit the target at that point. Once we do hit the target, that's not the end either, because patients over time can lose response and deviate from that target. And so we have to monitor to make sure that the target is maintained. And if it isn't, then the process starts over again.
So some of the patients who are watching this program may say, isn't that what we've always done? My doctor recommends a therapy and I try it, and if I feel better, I must be where I need to be. And if I don't feel better, I call and I complain or tell them I'm not feeling well. So how is this different? What does this do that's different than that?
This is really a much more proactive approach. We're really defining the target not simply as you're feeling better, but that we actually know that the disease is under control. And that means assessing the status of the inflammation in the bowel, not just how you feel, because those two things don't always match in Crohn's disease.
So how often is it that patients feel okay, but they're still inflamed?
It can be as much as 1/3 of the time. It's surprisingly high.
And what would be the consequence of that? I mean, what happens if that is going on?
If inflammation goes on in an unchecked fashion and it can be smoldering beneath the surface and you may not be aware of it, then gradually there is progressive damage to the bowel. That can't be reversed easily with medication. This might include stricture formation, or meaning a narrowing of scar tissue, or fistulas may form, meaning the disease process penetrates through the bowel and outside the bowel. Those things are very hard to treat with medications and often will require surgery. They're just not reversible otherwise.
So, Dr. Sands, you're a clinician, you take care of a lot of patients. Take us through how you explain the goals of managing Crohn's to a new patient.
Right. So when I talk to a patient about what I'm expecting, I want to clarify for them what their current status of their disease is. How much activity is there? How severe is their disease? And those are not exactly the same thing. Activity is sort of what I'm seeing at the moment for their inflammation and their symptoms. Severity is more about their trajectory of their disease. how rapidly progressing is their disease. And that is not that easily defined for everyone, but often can be predicted based on a variety of factors. One thing that patients ought to know for themselves is how much bowel is involved. Is it just a tiny little segment of small bowel, or are we talking about many inches or even feet of bowel? And that has implications for if I needed surgery for you, or if you needed surgery, what is the risk of that surgery? The next thing that is an important goal is to get the disease under control and do it fast. Time is marching on. As time progresses, there's more and more bowel damage. We're not talking about minutes, we're really talking about weeks and months that may make a difference, however. Plus, you may be feeling miserable, and we want you to feel well and to be functioning well. So we want remission of symptoms quickly, and we also don't want to stop there. As I said, we want to heal the bowel and improve it. Once we get you there, the goal of management is to prevent relapse, and that's more about maintenance of the disease. And then finally, we want to monitor you and do whatever we can to prevent complications of not only the disease, but also of the medications that we're treating you with, because all medications have potentially some safety issues that have to be monitored for. So we want to prevent complications of the disease or the treatment, which may include infections from both the disease or the drugs, in some cases, prevent you from being hospitalized. Certainly we want to prevent surgery if we can, although surgery is sometimes very helpful. And ultimately, we certainly don't want our patients to be disabled by these conditions.
And the emerging understanding of managing Crohn's disease has emphasized that when you are able to control the inflammation beyond just making people feel better, you can prevent some of these outcomes. And that's where the treat to target strategy has become more understood, and it's certainly the goal we want for our patients.
That's
so
right.
When we talk about remission, it's how they feel, but we want it to last. And in order to have it last, we need to have control of the inflammatory problem.
Correct.
Let's hear again what some patients had to say about what remission means to her.
Remission looks like being able to live my life fully without suffering from IBD, without putting things aside. I have activities that I can't participate in just from the symptoms and the pain from IBD. I have had to sit out from things, had to leave work early because of my symptoms. So remission to me is not having to do things like that where my life is impacted in a negative way.
So we certainly appreciate that many patients who've had Crohn's disease have had it negatively affect their life or impact their ability to function socially or at school or at work or to take care of family members. And one of the things that we really want to emphasize is that if we are able to control the inflammation, we're also able to give patients something that they definitely deserve, which is some knowledge of certainty. They're going to be less likely to have a relapse or have these unexpected episodes where they're sick if we know that their disease is under better control. And I try to emphasize that too as part of our goal as we work through these things with patients.
Yes.